Great. Good morning, everyone. How are you guys doing? It's a real honor to be giving this talk. I want to thank the University of Kentucky, their leadership and their wisdom for putting on an important presentation at this time of crisis for everyone. It's an incredibly, I think, meaningful initiative and something that I'm really happy to be a part of. We're going to be discussing the surgical management of frontal sinusitis. This is geared towards a resident audience, and if there is any, if there are any faculty or fellows in training who see this talk, there's certainly more to be discussed. There's a deeper nuance to the surgical techniques and so forth, but I think this is a very important sort of foundation for how we think about and approach surgical management of the frontal sinus. My name is Abtin Tabaee. I'm an associate professor at Weill Cornell Medicine, New York Presbyterian Hospital. I'm also one of the fellowship directors at our institution for rhinology and advanced endoscopic skull-based surgery. The goal is to discuss some of the key components of how to approach the frontal sinus. The foundation of this is always anatomic. We're going to do a deep dive into looking at the anatomy and some of the newer nomenclature ideas that have come out. And discuss some of the general principles of frontal sinus surgery technique. We'll also touch on coding and billing for this. The frontal sinus cavity itself, the sinus, not the recess, but the sinus, is a invagination and outpouching in the frontal bone. It's a pneumatization that occurs in 90% of people successfully. About 10% of people have either a hypoplastic or aplastic frontal sinus. Pretty high number. If you look at all your scans, you'll see this. This does occur at a regular interval. Of note, the aplasia or hypoplasia can be unilateral, as is seen in this scan of a patient with unilateral frontal opacification and a completely non-pneumatized contralateral right side. Within the frontal sinus cavity itself, there's variability in terms of the number of sinuses. While there are typically two, you can have multiple partitions dividing up the sinus into more than two. The position and the location of the septations can vary. There's often only one partition, and it's usually kind of close to the center, but it could be eccentric. Symmetry is also typically variable. Often there's asymmetry in the size and outflow drainage of the frontals from left to right side. And then the key anatomic component in terms of surgery has to do with the frontal recess itself. This is a schematic showing the outflow tract in its three components. The superior component right here is the infundibulum. This is an hourglass or funnel-shaped region. It's basically the inferior most aspect of the frontal sinus. This is the ostial region right here. This is the narrowest portion of the frontal sinus outflow tract. This is mostly defined by the exuberance of the frontal beak in terms of narrowness. And then finally, the recess itself is down here. This is largely influenced by the presence of ethmoid cells within the frontal sinus region. And this is going to be a continued theme of this talk, having to do with the anatomy and surgical approaches for this region specifically. It is mostly in the frontal recess that we're doing our surgical approaches for influencing the frontal sinus outflow tract, although some of the expanded techniques do allow for clearance of the frontal beak. In terms of looking at the recess, the sagittal view is the most useful because it comments on the anterior and posterior aspect of the frontal recess in terms of ethmoid cell development. This is also where our surgery is going to be focused. Important to point out, there's also a lateral and medial component of the frontal recess. The lateral wall is the lamina papyracea. Obviously, this is a fixed structure, nothing that we're going to surgically instrument. The medial wall is the middle turbinate, and this is an area for surgical technique, especially in the 2B, Draf 2B and 3 techniques. But for traditional frontal sinus work, we're mostly influencing the cells immediately posterior to the recess, and this is the bular region, or anterior to the recess, and this is the agarnazi or supra-agar cells, which again, we're going to discuss in detail. This is an important schematic. It also shows the position of the anterior ethmoidal artery. This is a little bit falsely reassuring. It suggests that the anterior ethmoid is far away from the recess, but in point of fact, this is a variable structure. It can be higher up, it could be further back, it could be low hanging, it could be embedded in the skull base. And so when you see all these structures in a single view, it makes sense, and it's easy to look at this as a surgical target, but the reality is we're working down here and looking upward. we're not looking at it surgically as a sagittal view. We're looking at it from an inferior perspective and trying to open these until we see the frontal sinus cavity. There's some question and concern, which really brings up the point that the only way you could ever understand someone's frontal recess before you open it is the CT scan. And this highlights the need to be very dogmatic and critical in the way you look at the frontal sinus anatomy in every single patient preoperatively on a high resolution CT scan, looking at all three planes. You get different perspectives in the various planes, and the sagittal especially is helpful for looking at the frontal recess anatomy. In terms of the anatomy we're going to talk about in detail, this is outlined here. We're going to discuss the uncinate process, the cells around the frontal recess, and some of the area above the recess. The uncinate process is the sickle-shaped bone emanating from the ethmoid bone. It's a sort of foundational part of doing a maxillary introstomy and then opening into the ethmoid cavity proper. But if you take a step back and before you even take down the uncinate, you look at its attachment point, you can predict its relationship to the frontal recess. In patients where the uncinate process superior attachment is on the lamina papyrica, the recess will be medial to this. It'll be between the middle turbinate and the uncinate process. In patients where the uncinate process connects superiorly to either the cribriform plate or another region of the skull base or the middle turbinate, then the recess will be lateral to it between the lamina papyrica, or in this case, a Haller cell, and the uncinate process. This relationship is clearly shown on a schematic and on a CT that's relatively free of disease. We do find this is less straightforward to interpret in patients with massive polypoid disease or patients who've had revision surgery. But if you do get a view like this, it is helpful. It can help you look for the recess even before you take down the uncinate and kind of predict the trajectory of where your work is going to be. I put up these slides as a reminder to everyone about how to think about the frontal sinus recess cells. This is the sort of old Kuhn criteria for describing frontal recess cells. We've moved away from this, and the reason we've moved away recently is that there's been some deeper thoughts on describing this anatomy. This nomenclature still has historic value. We still hear it sprinkled in conversations. And so I'm including it as a reference point, but again, we've moved away from this. I think the real limitation of this nomenclature is it wasn't descriptive enough, and it didn't show us a deeper understanding of what the cell in question, how it relates to the surrounding anatomy. So just to review, a type 1 frontal cell is a single ethmoid cell within the frontal recess above the agranasi. A type 2 cell is more than one of these cells, so you can have 2 or more still within the frontal recess. A type 3 cell is when the ethmoid cell encroaches into the frontal sinus cavity proper, so it extends above the beak, but still connected inferiorly to the frontal recess. And then a type 4 cell is a cell that's purely isolated in the frontal sinus cavity itself. This nomenclature has been largely replaced. This was a seminal paper, and for those of you embarking on sinus surgery, either at a postgraduate level or just in your practice, this is a really important paper to read, carefully study, and understand. It was published in 2016. Dr. Wormald was the principal author. It had a lot of input from some very important leaders in the field, including Dr. Wormald. And it's basically looking to make this sort of next level in terms of how we discuss and understand the frontal recess anatomy. So in place of the type 1 to 4 Kuhn nomenclature, we've moved now towards the a descriptive name. So kind of calling out these cells for what they are in their position, in their anatomic relationships. And we're going to go through these in detail. So these subsequent CT images are from that paper. And the paper does a really nice job describing these cuts, gives a few examples of each cell, and talks about the relationship. So a cell that's behind the frontal recess is going to be in some way related typically to the frontal bulla or the ethmoid bulla. So in this case, there's an ethmoid bulla proper, and there's a cell above it called a suprabullar cell. If this cell is not walled off and it's more just a space, so if you see a bulla and then above it an open space, that would be called a suprabullar space. Because of its position posterior to the frontal recess, pneumatization and expansion of this bulla will push the recess forward. And so if you're dealing with a very exuberantly pneumatized frontal bulla or suprabular cell, it's going to be an important aspect of clearing this region to give you access to the frontal sinus proper. If the cell encroaches into the frontal sinus cavity, so it's shown here kind of going above the beak, then it's called a suprabular frontal cell. Previously it was called a suprabular cell or space, and in this case a suprabular frontal cell. Same relationship in that it is posterior to the recess and will push the recess forward. The big difference in this case is that your dissection is going to start creeping up along this angle of the fovea transitioning to the frontal posterior table. And so you're going to be working much closer to the skull base in this curved section right here. If, on the other hand, the cell is anterior to the recess, it's going to be related in some way to the aggranazi. And so you can have one or multiple of these cells, but it's a supra-agar cell when it's still confined to the frontal recess. And as shown here, it's going to push the recess posteriorly. And so when you're working in this region, behind it will be the recess, and this could be pushed far back if it's a very hyperneumatized agar region. If the cell encroaches into the frontal sinus cavity, again, it's called a supra-agar frontal cell. Instead of a supra-agar cell, it's a supra-agar frontal cell. This is still anterior to the recess and still pushes it quite far back. And again, the challenge here is that now you're much higher, and the recess curve is going to be way up here. This is technically more complicated because your trajectory is going to be working from down here and putting your instruments up here. And so you can see this cell, and often it'll look like a very open space, and you might think you're actually in the frontal sinus, especially if you didn't anticipate this and look at your CT carefully. You will be misled to thinking you're done with your dissection, but the reality is there's another layer of the bony partition that you need to find. And ideally, you would find it sort of in this lip right here and pull forward towards yourself and then expand it posterior to anterior. But if this is really tightly opposed to the posterior table, you're going to find that that's going to be nerve-wracking and potentially dangerous. So the other technique you can use is just basically pop through this. You know, there's a huge amount of open space right above this lip. As long as you stay relatively anterior, you can push on this and get through it. And while you're not really connecting into the recess, that could be a starting point. And from here, you could take this lip further posteriorly and have an open connection. A frontal septal cell, as it implies, is a cell that's really connected to the superior aspect of the nasal septum. These tend to be eccentric, meaning they clearly have a drainage pathway. Physiologically, they're born with some opening draining somewhere, and it's typically either left or right, but not both. And you might get a sense from looking at the CT carefully that it seems to be maybe connected to the left side. And ideally, if you're going to explore this region, you would try to make it into continuity with the left side. There's also the potential for a supraorbital ethmoid cell. So this is a cell that's based on the roof of the orbit, and these can go quite far laterally. These are technically really complicated to assess, especially, or to address, especially if you're trying to clear the lateral wall. It could be far over. You might need to do Draf III. You might even need to do a tree find to get to that. As we mentioned earlier, the surrounding anatomy in relation to the frontal recess is complicated and potentially dangerous. This highlights the need to very carefully scrutinize the position of the anterior ethmoidal artery. And when we talk about positions, we really think about it in a three-dimensional sense. How far back is it in relation to the recess? How low hanging is it in relation to the skull base? And this is an extreme example of a very low hanging anterior ethmoidal artery. It's basically free floating, not really pedicled and not really encased in bone. And this means that as you're doing your ethmoidal work and you're starting to approach the recess, you're going to visualize this. It's an interesting commentary that earlier in my career, the dogma and certainly what I ascribed to was do your best to avoid this area. Don't even look at it. Don't dissect it. Just leave it alone. It's only fraught with potential disaster. And that is true. If you injure the anterior ethmoidal artery, it can be a catastrophe. It can retract into the orbit. You can get an immediate orbital hematoma requiring a decompression, potential for vision loss, certainly disrupting the whole surgical plan that you had for the patient. But that dogma of avoiding it and not visualizing it intraoperatively has kind of come 180. My current feeling, and I think most of us ascribe to this philosophy, is you're much better off identifying it early in your dissection. Once you've skeletonized the fovea ethmoidalis and you're starting to approach the frontal recess, visualize it endoscopically, confirm it with navigation, but there's nothing quite as important as seeing it. And then you know where it is. And once you visualize it, you can work more comfortably in front of it. You can identify that that's a danger zone. You see it, you know where it is, you can go back to it, just again, confirm where you're working is not near it. And you can be more aggressive and more comfortable doing the rest of your frontal recess dissection. Especially in a low-hanging anterior ethmoidal like this, I think you're going to be more successful in your frontal sinus surgery if you look at it. But on the scan, certainly review this as a key part of your preoperative planning. Also important is the slope and position of the fovea ethmoidalis. This is kind of a typical fovea, 15-degree slope, not a significant amount of drop-off. But every patient is different, and if you have a severely steeping anterior-posterior slope, that's going to make your frontal recess dissection more complicated because this is going to be in your field. You do also want to understand and respect that there is a need to look at symmetry. Not every side is the same. This is an extreme example of a much higher left fovea ethmoidalis than the right side. Each side is going to be different, just as every patient is different. The Keros classification for the depth of the cribriform plate has historically been and still is an important discussion point. While the millimetric numbers shown here have some value, especially in terms of research and stratifying people into high risk or low risk, I think the spirit of the Keros classification is the most important thing when you apply to a patient. And that is, if you have a patient like this that has a very long lateral lamella of their cribriform plate with not a lot of room for error when you're dissecting out these anterior ethmoid cells, it's a higher risk patient for a CSF leak. This is an incredibly thin bone, and it's very much in your field. And if you're not careful with your surgical instruments, especially the powered instruments, you're at risk for causing a CSF leak, either during the ethmoidal or the frontal portion of the surgery. This also points out the asymmetry that can happen in a cribriform position. And so when I look at a preoperative CT scan, I 100% carefully look at this relationship. How deep is the Keros? How deep is the floor of the cribriform? How long is this lateral lamella? Is there symmetry or asymmetry? I don't particularly do a millimetric measurement because I just need a general sense of this. And so instead of doing a millimetric measurement, you can just peek over, look at the medial rectus. And if you see that it's kind of close to the bottom of the medial rectus, you know it's a long cribriform. And you can see how much of the ethmoidal cells are still there if you're along this ridge. And if it is close and there's a lot of cell pneumatization, you know that this is going to be an important relationship. Now, the focus of this talk is about making decisions when you do your frontal sinus surgery work. How do you plan for it? How do you prepare for it? And so before you talk about technique and the beauty of surgery and how great your outcomes were, it's really important to take a step back and say, why are you doing the surgery? What is the goal of surgery? And we're specifically talking about the frontal sinus because there are unique qualities to the frontal sinus. But a lot of these components do cross over to the other aspects of sinus surgery. So for the most part, our goal when we do frontal sinus surgery is to achieve patency of the recess. There are surgical techniques that are aiming for the opposite, to close off the recess and take the frontal sinus out of circulation. But for the most part, what we're trying to achieve is structural patency. And that's a technical goal. It's carpentry, if you will. You're trying to take a closed space and make it open. You're doing that by clearing away structural obstruction. That could be bony partitions, polypoid tissue, anatomic variants. But at the end of the day, from a technique perspective, you're trying to create an open and patent outflow tract. At the end of a long healing period and influencing the recess with medical therapy, your ultimate goal for patient care is to restore mucociliary function and physiology, reduce inflammatory change, and equally importantly, access topical therapy. Now, this concept of topical therapy for sinus health has become foundational to how we take care of these patients. It could be saline alone, could be saline with steroids, saline with antibiotics. And this topical therapy access is sort of straightforward for the maxillary, straightforward for the ethmoid. But when you talk about the frontal, it gets a lot more complicated. The angulation to reach up there is challenging. The volume and the pressure required is challenging. There have been a number of very well done model-based studies that have looked at this, and it proves the point that even with a perfectly successful frontal sinus surgery, your access for topical therapy is going to be limited, with the exception of Draf III procedures. That's one of the main benefits of the Draf III is you get this huge, giant horseshoe-shaped opening It's continuous from one side to the other, and this topical therapy access is going to be profoundly well accessible for those patients. Now, as I mentioned, this is the goal for the majority of patients, but there is the role for saying some sinuses in the frontal region are just condemned. They're never going to recover for a variety of pathologies, whether it's a mucocele or severe osteotic changes, severe inflammatory polyp changes. Just, you're never going to get that cavity healthy. You've tried 5 times and you just can't get it to work. And there is a role still for talking about obliterating the frontal sinus. And we're going to talk about those techniques in a few minutes. So bottom line, your discussion points should start with saying, my goal is to create a wide open frontal recess, allow physiology to take over and access topical therapy. But there is in the back of our heads, for the very severe refractory patients, a consideration of saying maybe this frontal sinus can't survive. And unlike other sinuses, we do have the potential for taking the sinus out of circulation. At the end of this process, you still are taking care of a patient. So when you do any of these techniques, morbidity has to be managed. The risk exposure to the patient, the long-term outcomes of the surgery have to be justified from your surgery itself. Now, it's interesting, we're giving a talk on one of 4 sinuses, and you don't hear people doing extended discussions on maxillary sinus surgery or ethmoid surgery. That's all encompassed with sinus surgery. But right now, we parsed out a single sinus to focus on. And why is that? It mostly has to do with its complexity and challenge. The frontal recess anatomy is incredibly complicated. It's also highly variable. Patient to patient, it will look different, behave differently. And our ability to influence that anatomy is a lot more technically complicated compared to doing a maxillary antrostomy or a good ethmoidectomy. Part of this complexity has to do with the angulation needed to look into the frontal recess. You have to use angled scopes. And then to instrument the area, you also need angled instrumentation. This is a important point for those going through training, that the learning curve for sinus surgery isn't necessarily a straight line or a single curve. I view it more for my trainees as coming in sort of spurts. They get through a decent maxillary antrostomy and then get better with the ethmoid work, and then get better with the sphenoid work. And then eventually the frontal kind of comes into perspective for them. But each of those little steps where they got better at something didn't happen in clean continuity with the previous steps. There's a different surgical skill set and a different comfort level that'll come from each of those graduations. And I think the frontal work is probably the steepest learning curve. It is the thing that's most unlike the other work that they've done in the sinuses. And so as you are getting better at sinus surgery, it is appropriate and I think very important to recognize a need to be thoughtful, patient, methodical with your frontal sinus development. Frontal sinus surgery does not come easily to anyone. It takes a lot of work, a lot of experience, a lot of thought. And the sort of most important quality of this work is to be very analytic in the way you look at the preoperative CT scans, the way you do the surgery itself, learn from your mistakes, and respect that you're going to feel a little bit like a duck out of water, even though you got quite good at the other aspects of sinus surgery. That's okay. It's appropriate. It's the only way you're going to get good at this. And then when you get good at a traditional frontal sinus, Draf 2A or 2B procedure, then you can start feeling more confident to tackle something like a Draf 3 or a multi-revision procedure. But that takes time and it takes experience. Additionally, adding to the challenge of frontal sinus work is the visualization challenges. We are looking purely from a single perspective, right below the frontal recess. We can't see above it. We can't necessarily see the lateral and medial dimensions. All we can see is the undersurface. And so when we're working in this area, we have to be deeply aware of the surrounding structures and their risk exposure. We talked about the anterior ethmoidal artery, but the skull base and the orbit are equally at risk. The final challenge for all of us, even those of us who are experienced in this procedure, have done it for years and decades, is the potential for stenosis. This is a highly complicated and meaningful part of frontal sinus work, is understanding that a certain percentage of your cases are going to fail. We're going to talk about outcomes in a minute. And the reason they fail is that your potential outflow tract in the recess region is relatively narrow compared to other sinuses. It's not that maxillary antrostomies don't stenose. They absolutely do stenose. In fact, all of them probably stenose to some degree. It's just that your starting point is so open that some stenosis is meaningless. You could stenose up to 90% and you're still going to have a patent maxillary antrostomy. In the frontal recess, this is a much smaller circumferential space that even partial stenosis will completely obstruct. Adding to this risk of stenosis is the presence of inflammation, often the experience of creating raw bone, and the fact that your work is circumferential. So you're creating a raw wound that's rounded in an area that's inflamed, irritated, and surprisingly, they don't all stenose in this analysis. So some general principles about approaching the frontal sinus. In the way you approach this, it behooves you to use angled endoscopes. For some frontal sinus anatomic situations, you can use a 30. You can probably see most of what you need to see. But a 30 is often misleading for those with complicated anatomy, especially if the recessed cells start encroaching into the frontal sinus. You won't see the roof, you won't see the frontal sinus dimensions itself. So my starting point is a 45-degree scope, and often towards the end of this, I'll look with a 70, especially for those with high cells. And I think you have to embrace the need for 45 and 70-degree endoscopes in doing frontal sinus surgery to do this successfully. You need the proper instrumentation. There are a variety of different frontal recessed cold steel instruments out there. My favorites happen to be the curettes, the curved mushroom, and the biters. There's a curved frontal front to back and side to side biter. And I basically don't ever touch the cup forceps because they strip mucosa and they're sometimes inadvertently hostile to the tissue that I'm trying to be delicate about. So I use the biters, I use the curette. And then once the tissues have kind of been a little bit mobilized and softened, then a curved microdebrider, a 60 or 70 microdebrider is helpful. And I do this in continuity, back and forth, back and forth. Once you get good at the straightforward frontal sinus dissection, the other instrument that becomes really paramount to success is a drill. You have to become comfortable using a curved drill to clear off a thick bony beak or osteotic bone. Otherwise, you're not going to get through it with traditional instruments. In the course of your frontal sinus dissection, you do want to make sure your field is as dry as you can. So frequently decompressing and decongesting the area with decongestant soaked pledgets, letting it hang out for a minute and then looking and then doing a little more and then decongesting again and vasoconstricting again. And so this field requires patience and it requires you to be sort of methodical in the way you do it. Try to identify the recess early in your dissection. You can be aided from this by looking at the sagittal CT. Look for frontal recess landmarks that you can predict based on the CT. And for the most part, your trajectory should be away from danger. So when you use an instrument, in this case, like a curette, you want to move it in a posterior to anterior direction. If you move anterior to posterior and let's say that cell gives, then you're directly putting force on the skull base or the anterior ethmoidal artery. Similarly, you have to be thoughtful about not rocking either too far laterally or too far medially, but kind of being dead center with your instrument. The frontal recess can take any amount of force you give it. You're never going to hurt this, but the skull base here is quite thin. And so your direction, again, should be posterior to anterior. So in terms of describing the frontal sinus surgery approaches or techniques, sort of the basic way we think about it is endoscopic, open, or combined above and below approaches. And we're going to go through each of these. This is named after Wolfgang Draf, who was one of the key pioneers in the endoscopic era. He passed away a few years ago. Very, very thoughtful, kind gentleman. Influenced a lot of the leaders in the fields who are now our leaders. And he was a great mentor to many people, just a very outstanding individual. So this is the nomenclature he kept, he designed and described, and it's kind of stayed. I think it still has value, it still has meaning. And so when we talk about sinus surgery, we really talk in terms of draft procedures, Draf I, Draf IIa, so forth. So the Draf I procedure is actually not a surgery. It's basically a concept that when a patient doesn't have frontal sinus disease, the right thing might be to leave that region alone. So you do an anterior ethmoidectomy or total ethmoidectomy, but the frontal recess itself is not manipulated. The idea here is that the healthy frontal sinus should not necessarily receive additional surgery or receive any surgery at all. This is sometimes a difficult decision to make if a patient has varying disease and you maybe caught their CT scan at a relatively mild component of their health. But once you see a clear frontal sinus, it's potentially much more likely for you to harm that sinus by doing surgery than help it. This is somewhat of a debatable point. There are certainly surgeons where a full house FES is done in every single patient, but those surgeons tend to be seeing a lot more of the severe inflammatory difficult to treat chronic sinusitis and not sort of milder disease. The offside of doing that is you are going to create some iatrogenic frontal sinusitis if you do frontal sinus surgery in a healthy sinus. Now, Draf IIa is the workhorse of frontal sinus surgery for most routine inflammatory sinus disease. And this involves clearing the frontal recess cells, whether they be Agernazi cells, Buller cells, suprabular cells. But the goal here is to clear out all the frontal cells or the ethmoid cells within the frontal recess region. This includes uncapping the Ager or opening the Agernazi cell. And the neo-recess, once it's completed, is significantly wider, especially in the anterior to posterior dimension. The lamina propria hasn't budged, and so the lateral dimension is the same. And the medial dimension, the middle turbinate, hasn't budged either. This is where you've influenced it right in the middle, and on a sagittal view, you'd see a widening. This is the workhorse surgery. This is the foundation for doing frontal sinus work. This is the thing that we need to teach all of our residents how to be really good at before they graduate, so they can be successful in the community to take care of routine inflammatory CRS. The long-term outcome from a 2A procedure has not had that many publications of note, but specifically papers focusing on this do point out not only a high success rate, but a potentially high impact on patient care. So this is, again, Dr. Wormold's experience on 109 patients, mostly undergoing bilateral procedures. He commented on a 92% success rate based on endoscopic visualization postoperatively, significant improvement in symptom improvement, in this case, resolution. But if you look at sort of the finer number here, while it is 92%, that implies close to 10% of patients had surgical failure. And the stenosis event is real in one of the world's most regarded frontal sinus surgeons, P.J. Wormold. You see a 10% stenosis rate. Now, this correlated with small osteal size. So if you're starting with a very prominent frontal beak or narrow AP diameter, its best case scenario is going to be small, and so stenosis is going to be more likely in that patient. Stenosis was also more likely to correlate with persistent symptoms, infections, and polyps. And so the idea that your surgery technically didn't work translates into symptoms not improving makes sense, and it supports the idea that you did the right surgery, you did it for the right reason, you just didn't get the technical outcome that you wanted, and so the patient is still dealing with it. And that could help you kind of feel more confident to say, this is how far we got with the first surgery, so maybe we need to do a bigger surgery, still with the same idea that you're going to get healthier if we can get that cavity to be open. A 2B procedure expands on the 2A by extending the neo-recess all the way to the nasal septum. So you're clearing out the middle turbinate and a portion of the frontal floor. And so now your recess, it's still unilateral. You haven't crossed over to the contralateral side. And the anterior posterior dimension is the same. You're still clearing out the same frontal cells, frontal recess cells, but the cheat, if you will, the extension that you get is that you get a wider medial to lateral dimensionality of this. This is a really important, and in my opinion, a very underlooked surgery. For revision patients, really bad disease, they don't necessarily need to jump to a 3. Often you could do a very successful 2B, get almost the same dimensional outflow tract with a 2B as you would with a 3, but save some of the morbidity. You don't have to do a superior septectomy. You don't have to risk as much of the olfactory philia. You don't have to risk the skull base quite as much. And if you can get away with a 2B, that's sometimes adequate. So this is a patient with a complicated frontal recess, obstructive outflow tract here, an osteoma at the posterior table, a mucocele event with thinning of the posterior table back here. And so this patient had unilateral disease. They don't have a bilateral problem. And so the discussion we had internally was whether to go ahead and just make this a massive opening or give it a shot and do this unilaterally. So in my approach to this, we took down the osteoma, made a wide opening, extended it all the way medially because of this, the complexity and the amount of work involved. I wanted to give the person the best odds, but I didn't feel like a 3 was necessary. And so when we did the 2B, they healed very well. They were cured of their problem, and the contralateral side that didn't have disease is perfectly healthy. This is an important consideration in patients who are undergoing revision surgery, complex pathology. Those who you may not have a lot of room in an anterior posterior direction, so you want to cheat a little bit and get a little more medial to lateral dimensionality. If you're especially concerned about stenosis, or you're only have a one-sided disease, I think the 2B is a really important surgery. Dr. Peter Wong from Stanford, who's written extensively about the 2B procedure, including some of the outcomes, has highlighted this importance. He found at 16 months a 90% patency of 2B cavities that he operated on. There was a 22 patient series. It's important to note these weren't 22 healthy, normal, mild sinus patients. These were patients who were undergoing typically either revision surgery or complex pathology. And so the cohort here is much more likely to fail than the traditional 90% patency that you would see with a 2A. And so if you can get a 90% success rate on a 2B with a very difficult cohort, I think that speaks to the benefit of the surgery. The Draf III has become a really important aspect of rhinology. This has been around as a technique for a long time. The endoscopically modified Lothrop was described in the 90s, but I'm of the generation that we started sort of experimenting with the surgery in training and then a little bit during attending life. And then it sort of blew up in the early to mid 2000s. The discussion about Draf III really took off. And it's not that the surgery was new or the technique was dramatically improved upon in the 2000s. It's that there were enough people who could do it successfully and safely that it finally took hold for what it is, which is a really important I guess, endpoint for a great deal of frontal sinus surgery disease. Prior to that, if you have only 2 or 3 people who do the surgery, I don't care how busy or good they are, it's just not going to be popularized. But now that there have been really a wide proliferation of really well done rhinology fellowships and several years and years of fellowship graduates and those people then working in the community, the Draf III has become sort of a here to stay kind of surgery. It's meaningful, it's important, and there are enough practitioners who can do it successfully and safely that it should be considered in the algorithm of frontal sinus surgery work. The concept of a Draf III is to basically make a neo opening that expands from one lamina propria all the way to the other. So the entire frontal sinus floor is removed. All the ethmoidal cells in front of and behind the recess on both sides are cleared. A superior septectomy is performed. Both middle turbinates are removed. This creates a very wide opening, and it allows for a lot of potential disease to still not result in complete obstruction or stenosis. This is an intraoperative cavity patient of ours who underwent the Draf III. You can see this massive opening. You can take the intersinus septation within the frontal sinus all the way up. You can go from lamina to lamina. You can skeletonize the skull base, see the olfactory filia. And once it heals, you get this amazing cavity. It's massive, it's huge, it can drain. If one side closes off, the other side can still drain both sides. And equally importantly, you can access this whole cavity with topical therapy. You could do saline rinse with budesonide and it will get up there, whereas 2A or 2B, you're gonna be quite limited. There are still some relative contraindications to doing a Draf III. Potentially, if you've tried a Draf III and it's failed and it's become stenotic or osteotic, it might not just be a healthy enough cavity to survive a Draf III. It's a relative contraindication if you see dense hyperostosis. It's not that you can't do the surgery, it's just that it's a much higher risk of re-stenosing postoperatively. And in those patients, I think if you're going to go through the exercise of doing a Draf III where there's a lot of osteotic bone, you have to sign up to do a very aggressive clearance of that bone. Take it almost all the way through all the frontal beak tissue, all the diseased bone removed, if you're going to have any shot of that cavity healing very well. Relative contraindication is a narrow AP diameter. You can get away with a small AP diameter, but it's technically much more challenging and potentially dangerous. So in these patients, you might look at alternative pathways. In contrast to 2B, there have been a lot of papers written about the success rate for Draf III. And again, this is a skewed cohort of having more significant disease than other sinus surgery papers. These are patients who failed prior surgery, often multiple surgeries, or who have complex pathology, or both. And so when you see repetitive numbers from multiple groups commenting on 90% osteal patency, 80–90% clinical improvement, it speaks to the power of the surgery as being a really important tool for the very difficult to treat patient. The frontal sinus balloon is also an important adjunct to surgical approaches to the frontal sinus. This is sort of the extreme opposite of the Draf III in that it's minimally invasive. It does not do a great deal of surgical disruption. We all know how the balloon concept works, but just to quickly review, a guide wire is passed through the natural recess. The catheter is placed over the guide wire, it's placed in the frontal recess. The balloon is expanded. You typically get somewhere between 5 to 7 millimeters of expansion. These cells are not necessarily removed. They're just pushed out a little bit to give a widening of the frontal recess. This procedure can be done as a hybrid. You could theoretically use the frontal sinus balloon to identify, expand the recess, and then go in with endoscopic equipment and clear off these bony partitions. Almost like a very expensive and glorified frontal sinus seeker, but not a crazy idea for very difficult to find recesses to kind of start with this. This is also useful in the office setting if you've done a successful and proper frontal sinus surgery that just is failing postoperatively and you're starting to see stenosis. You can influence this during the early recovery period by passing a balloon in the office, re-expanding it, and trying to stay ahead of the healing process. A number of really well done papers have come out about the balloon. There have been a number of different important publications. Many of these are very highly performed studies, meaning they're randomized, they're controlled, they have an appropriate outcome measure, they're done over a long period of time. They give a 6-month and a 1-year follow-up. I think the only limitation, a lot of these papers are industry funded and sponsored, but in some ways it'd be really hard to replicate these studies without industry support. There's an important paper published by my colleague, Dr. Ed McCool in New Orleans on sort of a global view of balloon catheter dilation. So this was a very well done meta-analysis. This came out in the White Journal a couple of years ago. Very important reading, I think, if you're doing balloon work. It generally speaks to the quality of these papers and the fact that there is a meaningful positiveness to the balloon work. Important also is to be thoughtful about using the balloon. This came out of the Academy as a position statement about 2 years ago, lead authored by Jay Piccarello. And so this statement meant to put the balloon in sort of a proper context in the way you approach sinus surgery. It did comment that the balloon is for patients who have sinusitis, so that has to be based on clinical evidence and CT evidence of sinus disease. It's not appropriate for nasal obstruction. It's not appropriate for obstructive sleep apnea. It's not appropriate for headache as an isolated symptom. But in the right patient, it has a role. It's also probably not appropriate for complex patients, either because they've had multiple surgeries in the past, they've had balloons in the past, or they've had polypoid disease. So I think of it more as a useful tool in patients with relatively milder non-polypoid disease and those who maybe have not had surgery. Especially helpful in the office setting to consider this as an option for patients who are not great surgical candidates for whatever reason, including patient comorbidity. Part of the role of this was to support the role of balloon from an insurance carrier perspective, that it does have indications, it is appropriate, it can be done for frontal sinus work. And so this is an important thing that was done by the Academy to put all of the literature and all of the thought leaders' perspectives on this into a document that we can all point to and say, okay, this makes sense. It's very important we don't forget that there's a role for open approaches to the frontal sinus. This is the Trephination approach. It can be done through a brow incision. You can also do it through a Lynch incision. And the idea here is that you're going to access the frontal sinus cavity itself from above. This can be important if you can't get it from below, if there's a lot of bony scarring or really complex anatomy, or there's pathology in the cavity that you can't quite reach from above and you want to go from an above and below perspective, you can do a Trephination. This is also useful in those patients who have pretty severe, aggressive, active infection, like a Pott's puffy tumor, that you're just trying to cool off for a few minutes while you let the patient recover before you go in and try to decompress the frontal sinus surgically. You could do it together. You could do this, place a catheter or a JP drain and decompress from below. But important to remember that the Lynch procedure or the Trephination procedure has a very important sort of tool for you to access from above. These scars heal incredibly well. You want to preserve as much of the hair follicle as you can and try to bury it within the eyelash region. I'm sorry, eyebrow region. The osteoplastic flap is also an important tool to rely upon in the right clinical setting. If you look back historically, this was described in the 1950s, and for a great deal of time, this was a very important workhorse for bad frontal sinus disease. Things that we now tackle routinely from an endoscopic perspective were often viewed as osteoplastic flap friendly. And if you think about it, it makes sense. They did not have endoscopic techniques. They didn't have endoscopic visualization. Their instrumentation was pretty crude. You were basically reaching into a dark, bloody cavity and trying to pull out tissue. And so there's no way you're going to do a complicated advanced frontal sinus surgery from the nose. Even with microscopic technique, you lose your view almost immediately. And so the idea of taking the frontal sinus out of circulation made sense. It still makes sense for some patients. And the concept of the osteoplastic flap is still appropriate. I'm going to go over some indications for this in a second. So when you do an osteoplastic flap, it's through a bicoronal incision. You pull down the scalp, expose the frontal bone, outline the frontal table, the anterior frontal table. This was done traditionally with a X-ray view called a 6-foot Caldwell Luck. This is now I think more accurately mapped out with image guidance. You take a saw, you open the anterior table, you remove it as a flap of bone, pre-drill your plates so that you can know how to put it back when the time is right. And then you make a determination of whether you're trying to keep the sinus open. So you can open an osteoplastic flap and deal with pathology and then put the bone back and keep a frontal sinus patent. You don't necessarily have to obliterate it. So let's say there's advanced disease, some kind of osteoma lesion or a tumor of some kind, but you still think confidently the frontal sinus can still be preserved. Then you can open it from below, confirm that opening from above, deal with the pathology, put the flap back, and it's still a patent functional frontal sinus. Conversely, if you have a disease process that you've basically given up on, advanced osteotic bone at the recess, severe frontal disease that just never has cleared, it's called osteomyelitis, you've had some bony changes, some erosion, let's say, then you may look to do a obliteration, in which case you strip all the frontal sinus mucosal tissue, you drill it down with a diamond burr, meticulously make sure you've cleared every little nook and cranny of any potential mucosa, otherwise you're setting the patient up for delayed mucocele. Fill the dead space with autologous fat, and then replate the bone. This is for advanced pathology. It's complicated, and unfortunately, we just don't see it in the resident training as being enough of a volume for us to feel comfortable for most graduates to do this. So when you start in practice, if you have a need for this, it's important to recruit some help. Ask your senior partner, ask your neurosurgeon to do this collaboratively so that you can get through the surgery successfully. And then over time, you can take on more of the ownership. Cranialization also has a role. This is done in conjunction with neurosurgeons. In this concept, you're again taking the frontal sinus out of circulation, but instead of filling it with fat, you're bringing it into continuity with the anterior cranial fossa. So this is the kind of pathology you might look at cranialization: advanced, large mucopyseal, complete compression of the frontal lobe. This infected mucosal tissue is highly invaginated into the dura underneath. And so there's no scenario where you can clear off the mucosa but preserve the dura and then fill it with fat. You're just setting the patient up for a delayed intracranial infection. So in these cases, you take off the posterior table, from a craniotomy approach, you clear off all the mucosa, all the dura, you again polish all the invaginations of the frontal sinus cavity, and then you reconstruct the dura, and then you let everything fall forward. You need to obliterate the frontal recess. You can do that with a pericranial fat. You can use some muscle plug or bone fragments. But now your frontal sinus doesn't exist, and it's all just brain cavity. There'll be a period where the brain and the anterior table will have a little gap, but that eventually falls forward, and it's functional and physiologic with no harm to the patient. There's a variety of different adjuncts that are out there for surgical stenting of the frontal sinus. The image guidance I commented on here because I do think it's an important role. It has an important role for frontal sinus work. It can get quite bloody. You can lose some anatomic perspective. You might want to know how much of the beak you think you have left before you get to the dermal layer. So image guidance is really important. I think having a high functioning system with a high resolution CT scan and something that you work with regularly is really important for doing frontal sinus surgery work, I think, more comfortably. Shouldn't rely on it. It's just a tool, but it does have a role. There are a variety of steroid dissolving stents. Some of them are shown here. You can use a silicone sheet. You can roll this up. A variety of things are done. And interestingly, every surgeon does it slightly differently, which makes me think we don't have a perfect tool yet. Otherwise, we'd all be using it. But the idea here is to give some mucosal coverage, not create a raw wound, potentially add some expansive force to the recess that's trying to contract. The outcomes for these seem to be generally favorable. I don't think it's a make it or break it situation. I think there's still some debate about whether the cost of a steroid dissolving stent is worth any potential benefit. In my opinion, the foundation of surgery is not the stent, it's the surgical technique. And the better you do the surgery, the more likely you're going to be successful. And the stent is important, but again, it's just an adjunct. So a quick word about coding and billing, and this will conclude our talk. It's important for all the work you're going to be doing to get paid for the work you're going to be doing. And the foundation of coding is to do the documentation correctly. So this means operating on a patient who has a clear indication for surgery. They've got appropriate chronic sinusitis symptoms. They have a CT scan that demonstrates disease. You've done appropriate medical therapy and they still have persistent disease. The codes that are out there should be supported by diagnosis codes. So the ICD code for chronic frontal sinusitis is the most common one used. That's the one shown here. And then when you do the actual surgery, you have to have a operative report that details what you've done. So that includes the indications, the discussion with the patient about preoperative risk and so forth, the nature of the findings that you had intraoperatively, the anesthesia, and then a detailed narrative description of the procedure itself, step by step, what you did, how you did it, what you used to do so, so that any medical care provider, future surgeon, or the insurance company could look at your report and say, okay, well, this justifies the bill that you're submitting. These are the frontal sinus surgery codes that are out there. If it's a standalone frontal sinus surgery or frontal sinusotomy, it's 31276. If you're doing this with ethmoidectomy, it's 31253. If you're doing a standalone balloon dilation, then it's 31296. If you're doing a balloon of both the frontal and the sphenoid, it's 31298. The balloon codes are the same for office or operative use. There are also several different open surgery codes. There's a code for doing a trephine, for osteoplastic flap, and obliteration. Some of the coding pearls for frontal sinus surgery work. You can't bill for more than one procedure for a specific sinus. So let's say you did a balloon and an endoscopic approach. You can't bill for both. It's not supported by CMS. So you have to pick which one reimburses better or which one more accurately reflects what you did, but not both. Similarly, it's very challenging to get a reimbursement for both an open and an endoscopic approach. So if you did a trephine and an endoscopic surgery, it's unlikely you're going to get paid. Probably worth fighting them on this because it is significantly more surgery, more complicated, and they're really separate techniques, but it may be unsuccessful. The frontal sinus codes are unilateral, so if you do both-sided surgery, make sure you append with a 50 modifier. And for full FES, there's not really a right way of doing this, but the commonly done way is to carve out the frontal as its own code and do the combined ethmoid and sphenoid code. So you can do either an ethmoid sphenoid code or an ethmoid frontal code, in which case the other sinus is carved out as its own CPT. So this scenario where you do the ethmoid and sphenoid as a single code and the frontal as a separate code increases the RVU amount slightly. Not a dramatic improvement, but enough that it's probably worth doing this as your baseline. The Draf III procedures, Draf IIb procedures don't have a specific CPT code. This has been a back and forth debate at the higher levels of the academy and in our surgical societies. It's complicated. It's not a straightforward answer. But bottom line, there currently is no code. And so if you're going to do those procedures, it's appropriate to append with a 22 modifier indicating you've done more than the usual surgery. You have to support this with a detailed operative report and maybe an appeal letter up front to say that this is why I'm justifying the 22 modifier. It may not get paid, but it's still worth the fight. So in a quick summary of our talk, the foundation for frontal sinus surgery comes back to the anatomy of the frontal recess, understanding the general concepts from papers and anatomic discussions, but also looking at each individual patient's CT scan to fully understand what the frontal sinus in that patient is going to look like during the surgery. This is a very systematic and important assessment of the patient before you operate on them. And as you're planning your surgery, it's important to consider all the options, especially for more complicated disease. 2A may fail enough of the time that you should always kind of have in the back of your head the role of a 2B or a 3. In patients who don't have frontal sinus disease, don't do any procedure, including a balloon. There's no indication for that, and there's no potential benefit you're going to instill for the patient. Those with relatively milder disease, you could certainly do 2A, you could do a balloon. More complex disease becomes very individualized. You have to think about the patient's specific disorder and what the surgery is going to potentially achieve for them. There's no black and white algorithm. I think this is an ongoing discussion of who gets a Draf 3, who should get a 2B, who should consider obliteration. Surgeons will differ on the way they approach this question significantly. And so if you look for one answer, you're not going to get it. It's going to be all over the place. So that probably invites a healthy debate and maybe some more research in this area. Finally, my last point is to respect the frontal sinus. It's an area that's technically more complicated. There's a higher risk of complications. Even if you do a clean surgery, you can still get stenosis and have persistent disease. And so as you approach the frontal sinus in your surgical growth and you're taking care of sinusitis patients, this requires a little bit more expertise, maybe a little bit more training. And the Academy every year has very good lectures on different experts on how they approach the frontal sinus. And I would encourage you to take those lectures and maybe do some cadaveric work as you're getting better and better. With that, I'm going to stop. Thank you very much for your attention. And thank you again for allowing me to participate in this important initiative. Thank you.
Thank you so much. Really appreciate you giving a talk. I'm sorry the live attendees have sort of fallen off, but a lot of people are watching the videos later on, like about a couple hundred.